Thank you very much, Nemu. Good evening, everyone. I'd like to thank you all for joining us this evening for this Medicine for Members event. In particular, I'd like to offer a warm welcome to those of you who may be joining us for the first time. I'm Dr. Kevin Rush. I was recently appointed as a public governor at CUH. In fact, I've only been a governor for 6 days, so please bear with me. My background is in clinical pathology, so I'm very interested in tonight's topic from a scientific perspective, because any technique that enhances the earlier detection of breast cancer is good news as far as I'm concerned. Before I introduce the speakers, I'd like to say a few words about the benefits of Cambridge University Hospital Trust membership. If you're not already a member, I would urge you to consider joining. Membership is open to anyone over the age of 16, and this includes patients, carers, staff, and members of the public. We need members' feedback and opinions to help Addenbrooke's and the Rosie hospitals to continuously improve and develop. Membership offers access to health-related events, such as these Medicine for Member lectures, plus listening sessions and other experiences across the campus. As a member, you'll be eligible to stand as a governor to represent the needs and views of members, or to vote in the annual election to the Council of Governors. And on that point, I'd like to say thank you to any of the members present that might have voted for my recent appointment. Thank you very much. Please help us swell our membership ranks by joining us. You can sign up via our website at www.cuh.nhs.uk. Excuse me. Before we get into the presentations, I'd like to point out that in view of the number of people attending, it may be unlikely that we'll be able to answer all the questions that arise. So to save time, please enter any questions via the chat box during the presentation, and I will try to pick the more generic questions that give answers to a wider number of you. We can then follow up with questions that may be more specific if we have time. I'd now like to introduce tonight's speakers who are going to talk about breast cancer screening and what to know about dense breasts. Professor Fiona Gilbert is a consultant here at CUH. She's an academic radiologist with a clinical focus on breast cancer. Her research interests include early cancer detection, imaging biomarkers, and novel techniques such as sodium magnetic resonance imaging. She also leads work on the use of artificial intelligence in radiology and collaborates with academic and commercial partners to develop and evaluate AI tools. She has over 300 peer-reviewed publications and has over £26 million worth of grant applications. One of her works, the BRAID study, compared the use of supplemental imaging techniques in women with dense breast tissue with the routine mammography currently used for the detection of breast cancer. Our second speaker tonight is Louise Duffield from Ely. Louise has kindly given us some details about herself. She's a 60-year-old grandmother of 4 and works in local government. In her spare time, she enjoys knitting and attending 1940s historic events with her husband Fred and their beautifully restored US Army Jeeps, which she tells me one is just being rebuilt this evening, in fact. She's enthusiastic about clinical research and has taken part in several studies as a healthy volunteer. In 2023, Louise was invited to take part in the BRAID trial after her negative routine mammogram showed that she had dense breast tissue. Thanks to the trial, she was one of 85 women whose cancer was detected early. Our final speaker tonight is Jonathan Lawson. He's a former scientist that now supports the communication of research here at CUH. His role involves raising awareness of the research being undertaken and encouraging more people to take part in the research studies. So thanks to all of you for agreeing to talk. And I'm now going to hand over to Fiona and Louise for the first part of the presentations. Thank you, guys.
Kevin, thank you so much for that very kind introduction, and congratulations from us. It's such an important role that you've taken on, being part of the board of CUH. The board's role is invaluable, and it really holds us to account in the delivery of healthcare to the people of Cambridge and the surrounding area. And so, you know, it's such an important role, and I suspect it's unpaid and not, you're not often thanked, but thank you so much for doing it. And we'll look forward to hear how you're getting on in the role in due course. I'm going to share my screen if that's okay.
Sure, thank you.
And now can we see my screen? Is that okay? Yeah.
Yep, that's
Great.
all fine.
Great, thank you so much, Namu. So this evening I'm going to talk about breast screening and breast density, and really focus on a piece of work that we did really over the last 7 years. And it was called the BRAID trial, Breast Screening Risk Adaptive Imaging for Density trial. And the people named on the screen in front of you are the amazing collaborators with whom I worked from different sites. Paul Farrow and Antonis Antonio was from Cambridge, together with Nick Payne, medical physicist, who basically ran our trial database and helped with all the QA for the imaging. Iris Alajbu is one of the radiologists here in Cambridge, was kind of instrumental in helping us assess women in Cambridge. And then the other people on the listed here are from different sites, and the PIs at the 10 different sites from where we recruited women. So what is it that we're concerned about in the screening program? Well, first of all, we always have to kind of give our disclosures, and the trial was funded by Cancer Research UK, and I was fortunate enough to get one of their early detection program grants, and this was jointly held with Professor Paul Farrow. And what we bid for was money to do this study, plus also do work on artificial intelligence. But that's maybe for another meeting, Kevin and Namu, if you'd like. We were also fortunate in getting funding from GE Healthcare. GE Healthcare, I'm sure you've heard of them, a very big company, but one of their arms is in imaging, and they develop healthcare imaging equipment. And one of the tools that they developed about, maybe more than 10 years ago, was a whole breast ultrasound machine. And this basically does what it says on the tin. It images the whole breast using sound waves. And one of the issues that was being put forward was that, and other countries were suggesting this, was that maybe people with very dense breast tissue where mammograms are not so sensitive, maybe ultrasound could be used as an additional imaging technique. And so GE Healthcare were very keen to have this technology tested. So they lent us 3 machines. Bayer Healthcare were kind enough to give us free contrast media for the MRI scans, which was another of techniques that we thought would be useful for people with dense breast. And then, of course, our National Institute of Health Cambridge Biomedical Research Centre, we get a huge amount of funding each year for them. It was certainly over 85 million that we get. And this is in over a 5-year period. And this is to support research for patients. And the money is spread over lots of different specialties, and imaging gets some support here, and we got support from them to deliver this study. And then the other very important network was this clinical research network, which has really been developed across hospitals in the UK to allow us to help recruitment into studies and then to also do follow-up. So all of these people, so already I hope I'm giving you a flavour of the complexity of doing this kind of big trial work. You need lots of support from lots of different people. But what is it I'm talking about here? Well, in the UK, we invite women who are aged between 50 and 70 to come for a breast x-ray, a mammogram, every 3 years. And they're invited through their GP practice, although it is actually the screening centres, the 70-odd screening centres in the UK, who actually send out the invites and organise the programme. But one of the challenges that we have with breast x-rays is that it's basically x-rays are shot through a compressed breast tissue onto a plate which records the amount of radiation that hits the plate and converts that into an image. And if people have a lot of breast tissue, then the breast tissue absorbs the x-rays. And so not very many x-rays reach the plate, the receiving plate. And so that appears white, whereas x-rays that go through the fat in the breast, that appears black. And the problem that I have, and all the readers of the breast x-rays have, is that if you've got lots of breast tissue, then the mammogram appears mainly white. Not sure if you can see my arrow. Can you see my arrow here on this image that's labeled D? So this is the D density, the densest breast tissue. So there's lots of white breast tissue because the x-rays, the radiation is being absorbed by the breast tissue, and so it's just appearing white on the breast x-ray. And my problem is that cancers also absorb x-rays, and so they appear white as well. So I'm looking for white and white. I'm looking for a small cancer here in amongst all this white tissue. It's actually incredibly difficult to do that. And we know that people with this very dense breast tissue, it lowers the sensitivity of the mammogram, but that mean the number of cancers that are picked up compared to the total number of cancers. And the other issue is that people with very dense breast tissue are more likely to develop breast cancer. So it means that the people most at risk of developing breast cancer have the biggest problem because we can't see them on their breast x-rays. So helpfully, the Americans categorize breast tissue into A, B, C, and D. So A is fatty breast, where it's relatively easy to see cancers, but actually not very many cancers develop in these breasts. B is where there's a bit of dense breast tissue here, more breast tissue in the C's, and in this very densest category, the BI-RADS D, it's very hard to see the cancers. So there's been a number of different studies that have been published in America and also across Europe who all agree that there's decreasing sensitivity of the mammograms with increasing breast density. And this slide's courtesy of Melissa Hill, who worked with a company called Volpara, who measure the volume of dense breast tissue. And you can see here I've plotted again, or she's plotted against the number of cancers, the sensitivity of the mammogram, which is high, between over 75 to almost 95%, compared to the BI-RADS D category, this very dense breast tissue here, then it's dropping to between 50 and 70%. And this has been shown across numerous studies. So we know we have a problem, and it's why a number of European studies are already offering ultrasound screening to those people with very dense breast tissue. I mentioned also this issue of women are at increased risk of developing breast cancer if you have more breast tissue. And again, this has been shown in a number of published studies which show that people with the highest breast density are at most risk of developing breast cancer. So when you compare the very fatty breasts to the densest breasts, it's about a 4-fold increased risk of developing breast cancer. And what we did in Cambridge, and this was work that was led by Nick Payne, Dr. Nick Payne, who's a medical physicist, and what he showed when he analysed 50,000 mammograms or cases from our 3-year breast screening programme in Cambridge, he showed that the women with the BI-RADS D category, we found 16 cancers per 1,000, and half of them, well, almost half of them, 48%, were cancers that occurred between the 3-year screens. So these were what's called interval cancers, the cancers that occur in the interval between the 2 screening examinations. And when we compare this with the BI-RADS A, only 7 cancers, a total of 7 cancers per 1,000, and only 25% of these 7 were interval cancers. So we know we've got a problem. We're not serving women who've got the densest category of breast tissue well with just offering them mammography. And actually, when we look at BI-RADS-C, and that's another kind of 25% of the population, again, 14 cancers per 1,000, and 40% of these were interval cancers. So we felt that, yes, the published data said there was a problem with sensitivity of mammography and increased risk. And when we looked at our own local data over a 3-year period, yes, we confirmed this, that there's a local problem in the UK as well. So this led us to design this study about which supplemental imaging technique should be offered to women after 2 people have read the mammogram and said, yeah, it's normal, we can't see anything here. You know, which of the imaging techniques would improve early cancer detection? By that, I mean detection of small cancers in women with dense breast tissue. And in the trial, we included women with both BI-RADS-C and BI-RADS-D. So about 34% of the population were being offered this additional imaging. And the test that we wanted to compare was a magnetic resonance examination, which is basically a fast examination, not a half-hour examination, but a 10-minute examination. And we wanted to compare this with contrast mammography. And by this, I mean, basically, we inject iodine into the bloodstream and then take the breast X-ray in a similar way that when you're doing a CT scan, we inject iodine into the bloodstream. We inject about 100 ml of iodine into the bloodstream and then do the CT scan. Well, the same thing. We inject iodine into the bloodstream and then we take the breast X-ray. Or this ultrasound, this sound wave examination, the whole breast ultrasound examination with the equipment that was being lent to us by GE. So what we decided to do was do a randomized controlled trial of over 9,000 women between the ages of 50 and 70 who attended the breast screening program, who were found by the readers to have either C or D breast density and had a normal mammogram as read by 2 people. And then what we decided to do was we'd offer them imaging, one of these 3 tests. We'd randomize them to one of these 3 tests or the control arm. And then we'd repeat the imaging again at 18 months' time. And they would go back to the normal screening interval of a 3-yearly mammogram. And our primary outcome measure was cancer detection rate. We wanted to see, can we increase, or which of these 3 tests was better at improving our early cancer detection rate? And our secondary outcome measures were what were the recall rates, what were the biopsy rates, what was the tumour size, and what was the grade of these cancers. So this is what we did. I'm not sure if you can read this. So we randomly allocated the screening batches before the woman came for screening. And then once they'd attended screening, so they'd already been pre-allocated to ultrasound, contrast mammography, ultrasound or MRI, the control arm. And then if their mammogram was normal and they had C or D breast density, we rewrote to them with our normal mammogram result and said, would you like to participate in this study? So our aim was to recruit over 2,000 people in each of these arms from the 10 sites and then offer them supplemental imaging again 18 months later and then look at the results. So these were the centres that took part across the UK, 2 in Scotland, the rest in England. And as I said, we got over 9,361 women into the trial. And we got more than 2,000 women in each of the intervention arms, and our standard of care arm was 2,500 women. The median age of the women participating was 56 years, which was great. 83% were in the BI-RADS-C category and 16% were in the BI-RADS-D category. Now, we had a large number of people, almost 500 people, withdrew from the study before they had the supplemental imaging. And just to put this in context, we started the trial in October 2019. And of course, everybody remembers very clearly what happened in March 2020. COVID struck. And so basically we had to stop screening So we were told to stop all trials and move all research staff to do COVID research. And so we basically had to pause the trial. But we'd already recruited women into the study, and then it was very slow to start recruiting women again, because understandably, it took a while to move staff back onto doing non-COVID trials. And also it took us a while to get the screening program restarted again, because women understandably were hesitant about attending hospital, because of course that was where the kind of COVID hotspots were, if you like. So we had a number of people who withdrew from the study, or they didn't like the arm that they were allocated to. The 100 people unable to attend imaging, and we didn't kind of pursue why they didn't want to come. We assumed there were kind of some COVID reasons there. We were running another study at the same time, the MyPEB study, which is a personalised breast screening study where we're looking at the interval of screening. So small numbers were participating in that study, and in 200 no reason were given. So it was about 8% of the women in the MRI and contrast mammography arm withdrew, and 4.5% in the ultrasound arm. Now, what were our results? So, as I said, over 2,000 people in each arm had the scans. The median time interval between the initial screening examination, the screening breast x-ray, and the supplemental imaging was about 3 to 4 months. Our recall rates were about 9.7% for the MRI and 9.7% for the contrast mammography, and only 4% for the ultrasound, which was very heartening. So quite high recall rates. On average, we recall about 4% of women just from the breast x-rays into the screening program. We don't like to recall too many women because it causes short-term quite high anxiety levels. Our biopsy rates for the three techniques were between 4.9% for the MRI, 4.4% for contrast mammography, and only 1.5% for the ultrasound. So at the moment, it's looking quite promising for ultrasound with low recall rates and acceptable biopsy rates. But when we looked at the cancer detection rates, MRI and contrast mammography were 4 times as sensitive than the ultrasound examination at detecting the small cancers. We were really surprised at the contrast mammography results because there'd been very little published data on contrast mammography in a normal screening population. There'd been a big Dutch study looking at full protocol MRI, that's the half hour, the 30-minute MRI examination, which found 16.5 cancers per thousand. So we were delighted with our very rapid MRI examination, the 10-minute MRI examination, to find 17 cancers per thousand. So these were kind of very pleasing results in terms of the sensitivity of these techniques, but in some ways quite shocking about how bad the mammography actually was. So as was said earlier, 85 cancers were detected, 73 of them were invasive cancers, and 12 cancers were what we call ductal carcinoma in situ. So this is the precancerous stage when we see malignant cells in the milk ducts, but they haven't yet invaded into the breast tissue. So these DCIS cases are excellent prognosis. Some of them do go on to become invasive cancer, so it is good to find them, and we often perform surgical procedures to remove the ductal carcinoma in situ. But 73 invasive cancers were found. So when we look at the precancerous stage, the ductal carcinoma in situ, 3 were high grade in the MRI arm, 6 were high grade in the contrast mammography arm. These are the cases that we really want to find. And then the low grade ones were 2 in the MRI arm and intermediate 1 in the contrast mammography arm. And variable sizes between 10 and 27 millimeters median size. But when we look at the invasive cancers, we found small cancers in the MRI arm and the contrast mammography arm that was 10 millimeters median size in the MRI arm, 11 millimeters in the contrast mammography arm, but there were 22 millimeters in size in the ABIS arm. So to put it in context, one of the quality assurance parameters that were measured on in the breast screening program, when people are checking up to make sure that we're doing our job properly with the mammograms, then we're expected to find over 80% of cancers under 15 millimeters in size. So basically the MRI and the contrast mammography were meeting that very important quality standard for the screening program, that these techniques are finding small cancers. Whereas the ultrasound examination is finding cancers that are already over 2 centimeters in size. And once cancers are bigger, our fear is that, and from what we know about cancer biology, that these cancers, when they're bigger, have already spread to lymph nodes and other parts of the body. So that's why the screening program is fixated on finding cancers that are under 15 millimeters in size. And you can see the interquartile range here for MRI and contrast mammography is up to, at the higher range is 15 millimeters. So that's why we think the MRI looks really promising, as does the contrast mammography as a supplemental imaging technique. When we look at the grade of the cancers, we didn't find very many grade 3 cancers. We're not sure why that is. But in the grade 1 and 2 cancer, or the grade 2 cancers, the intermediate cancers, we certainly want to be finding 18 for MRI, 6 for ultrasound, and 21 for contrast mammography. The grade 1 cancers are an interesting group because one of the things we're always concerned about when we introduce new, more sensitive techniques into any screening situation is that you start finding disease that might never have been found in a woman's lifetime had you not done the intervention. And this is called overdiagnosis. And the policymakers and public health officials get concerned when we find too many grade 1 cancers because they say, would they actually have been found in a woman's lifetime? Are we not now just labeling somebody with cancer and she would never have known about it had she not attended for screening? So that's a kind of caveat that we need to remember when I'm getting very excited about these very impressive sensitive techniques. So that was the first round of screening. But the second round is actually in some ways more important. And just to go down to this bottom line here, CDR, cancer detection rate per 1,000 women screened. So this is women we've already found, with MRI, we've already found 17 cancers. We're finding 18 months later, another 8.6 cancers per 1,000. And in ABIS, 9.5 cancers per 1,000, and contrast mammography, another 7 cancers per 1,000. So this means we should not be ignoring these women. There's many cancers there which are going undisclosed, and we're maybe not even finding it the next round of screening. The recall rates, thankfully, when we did the next round, remember these women had already had an MRI examination, they're having another MRI examination 18 months later. We had stopped recalling so many people. We're now under that kind of 5% level for all 3 techniques. So this suddenly becomes more acceptable to the National Screening Programme if we can keep the recall rates down. We're not recalling women unnecessarily. And similarly, the biopsy rates are low as well. So just to show you graphically, the recall rates in the first round and then the second round dropped. Similar recall rates for ABIS. For contrast mammography, they drop satisfactorily. The biopsy rates are dropping to acceptable levels, and the cancer detection rate very high in the first round, but then falling back to about 8 per 1,000 at the 18-month interval. So it means these techniques are very sensitive when you add them into mammography, and the cancer sizes that we're finding are also acceptably small. We want to be finding small cancers in screening programs. So what on earth is it that I've been warbling on about? Well, this is an example of ultrasound examination. This is when you're looking at the whole of the breast, looking down on it like a kind of helicopter view. And this is when we're looking side on through the breast. We look at multiple slices, and this kind of black thing here, I'm not sure you can see it, is the cancer that's absorbing the sound waves. This is a contrast mammogram. This is all the white breast tissue in the low KV image. In the high KV image with the contrast, you can see the white cancer and it's just lighting up like a, Felicia beacon. It's like amazing. It's so easy to see because that background breast tissue just disappeared, and that's because cancers have leaky blood vessels. So when you inject contrast into the bloodstream, the contrast leaches out into the cancer, and you can see it very clearly in the contrast mammogram. And similarly with an MRI scan. So MRI scan is basically it's kind of radio waves and a strong magnetic field, and then you inject gadolinium into the bloodstream, and again the gadolinium leaches out into the cancer, and you can see these bright cancers here lighting up in amongst the dense breast tissue here. So interestingly, in the second round of imaging, the mammogram still picked up 5 cancers that wasn't picked up by one of the screening techniques. So it looks as though we'd still have to be doing mammograms, which is an important piece of information. But in summary, basically, both contrast mammography and this fast MRI examination showed very high cancer detection rates, which then fell to 8 per 1,000 at 18 months. And remember, this compares with 8 per 1,000 cancers in a 3-yearly screening round in these women with the dense breast tissue. We had high recall rates initially, but they dropped to under 5%, so that's acceptable to the screening program. And basically, the cancers that we were finding were of small size when we used MRI and contrast mammography. ABIS wasn't able to do that, and mammography was an important measure. In order to persuade or really convince the screening program, I have to say Louise has been just doing the most brilliant job advocating that we should be changing our screening program, and she did fantastic work when Jonathan arranged an amazing number of interviews for us when we published these results. We do need to wait and see whether we can reduce the interval cancers and the next round cancers in this cohort of women. So that'll be a few years later. But what we really need to try and do is convince the screening program that we do need to be making changes. Fortunately, they're going to do some cost effectiveness work and look at long-term effectiveness of introducing these supplemental techniques. But we do hope this study will guide the future screening policy. But what I'd like to do now is ask Louise if she could then maybe share her personal experience of what it was like participating in the study, what it felt like being told she had dense breast, and then coming and having the test. Louise, you're on mute.
That's it. That's better. Thank you, Fiona. Thanks for that. And thanks for all your work with the study. It really has been life-changing for me. When I had the initial MRI, everything was clear. Fast forward to the second lot at 18 months, and I was picked up as having DCIS. And we were looking at 5 or 6 tiny little flecks about the size of a grain of sand, which were inside the duct. And in the few weeks it took from my biopsy and diagnosis to having the operation to have the duct removed, it had already started to break through that duct. Fortunately, having been on the study, it was a very, simple procedure. It hadn't transferred into the duct, so it was just a matter of day surgery to remove that duct, slightly bigger than it was initially anticipated, and then followed by 5 sessions of radiotherapy. So hopefully when they look at the cost-cutting exercises, they'll see that I didn't have to have a mastectomy. I didn't have to have reconstruction. I didn't have to have chemotherapy. So my impact on the NHS was obviously so much less, having been picked up very, very early on. And I'm doing all I can to help and hopefully get this change of screening process for those of us with dense tissue. To summarise, I still wouldn't know now that I'd even got an issue if I was on the normal 3-year mammogram program, because my routine mammogram wouldn't have been due until in the next few months. So I would still be totally oblivious, and it may not have even picked it up on that mammogram. So I am incredibly lucky to have been taking part in the study. As I say, I think it's been life-changing for me. Let me know, Fiona, if you need me to explain anything else.
Can I ask you, Louise, how did you feel when, because one of the concerns is explaining to women they've got dense breast tissue. How did you feel when you got the letter say your mammogram is normal, but you had dense breast tissue? Was that a worry?
Yeah, at that point, I wasn't really aware of what difference it made. It was only afterwards that I found out that obviously there is an increased chance of getting breast cancer with dense tissue, and it's not something that is normally told to you as part of the mammogram screening. It is in America. I think it is by law that they have to tell you if you've got dense breasts, but in the UK that isn't told to you, so you're unaware. And like I say, I still wouldn't know now that they were dense if I hadn't been taking part. Which again is it was a bit of a shock to find out I'd got an issue, because it's something that wouldn't be able to be picked up with self-examination, although self-examination is still very, very important, and it is something I still do on a monthly basis. And I do mine on the first of the month, because you tend to remember the first of the month, and it becomes part of your routine. So I still do that, as well as I will still go for my mammograms. But again, I forgot where I was going to go now. I can't remember now. Anyway,
I can interrupt you, Louise. I'm sorry, but we are running a little bit out of time. So it's thank you very much for what you're doing. Is there anything else you'd like to add before we switch over to Jonathan?
No, I can't think of anything. No.
Okay, thank you very much. I'm sure we're going to come back to some of these things in the questions anyway. So on that note, then, if I can hand over to Jonathan to give us an insight of his work and the research that's ongoing.
Yeah, sure. Thank you very much, Kevin. Thank you so much, Fiona and Louise. It has been brilliant working with both of you over the last couple of months on sharing the story of Braid, and I know it's great to be reading in the chat as well about how personally involved a lot of people are in this, and how important this is to so many people. So as I said at the start, my role is about supporting awareness of research at CUH and across the hospitals. So that's both Addenbrooke's and Rosie. At any given time, we can have over 16,000 people involved in research studies, and about 700 research studies running, with about 200 coming on each year. So there is a huge amount of research that goes on across our hospitals. And that's actually a really important thing that people aren't often very aware of. So you can find online, there is an NHS England website which explains about the importance of research within the NHS. And it's really interesting to note that not only does it benefit in terms of the direct outcomes of research, in terms of allowing patients to have access to treatments and technologies that they wouldn't normally have access to on the NHS, for example, this supplemental imaging, but also there is a lot of evidence that shows that the more hospitals engage in research and the more that patients at hospitals participate in research, that delivers benefits both in terms of patient outcomes, so most dramatically mortality rates, as well as patient experience of participation in healthcare and their experience of receiving healthcare. And it also benefits our staff in terms of them being able to be involved and being able to feel that they have a more direct beneficial effect on innovation and progressing healthcare for patients. So research is really important, and it is the ambition of the NHS as laid out in the 10-year plan that was published last week, as well as an ambition for CUH and our hospitals to encourage and to enable everyone to have the opportunity to participate in research. So with that in mind, at CUH last year, we launched the Love Research campaign. And if you want to know more about this, you can find this under the research section of the CUH website, cuh.nhs.uk. And within that, you'll find guidance and instructions on how to participate in research through the MyChart app. So if you have, it's logged me out, which is super helpful, but if you have MyChart and you use it to manage your engagements with CUH, then you can go into MyChart either on your computer or on your phone and express your interest in being contacted about research. So we have an explanation of how you can do that within the CUH website. And it is a fairly easy thing to sign up to do. There's not a lot that you actually have to commit to. So it's called Consent to Contact. And the easiest way of finding it is by going to the research part of the menu, which is the sort of 3-layer burger thing that comes up in the top corner in either the app or on the top corner of your browser. And you can scroll down to the resources section where you'll find research studies. Within research studies, there's the participation preferences bit where you can choose either OK to contact, which means you would like to be contacted about opportunities to take part in research, or do not contact if you don't want to know. And you can then create a profile where you say what kind of research you want to take part in. And essentially there are 2 main aspects of research. One is observational. So this is basically just allowing researchers who work with CUH to take a look at information that is already stored within your health data without you necessarily actively needing to come to the hospital or participate in any studies. Or interventional studies like BRAID, where you potentially get additional tests or additional treatments that both serve to benefit people in the future by developing research and hopefully leading to new treatment guidance, but could, as you've seen with Louise, also lead to personal benefits for you too. As you heard during Louise's introduction, you don't have to be ill or have any kind of illness to participate in research. You can participate as a healthy volunteer, and obviously coming into BRAID, Louise was one of these that, as far as she was aware, she was perfectly healthy. If you don't want to do it through MyChart and you're too much of a technophobe to want to play around with the apps, that is also perfectly fine. The easy way of addressing that is whenever you're engaging with a member of our staff at CUH by having an appointment, then you can also ask for your interest to be researched to be expressed within your electronic patient record whilst you are here talking to us. And it is also worth noting that even when you have expressed your consent to be contacted about research, if you do want to know about research studies that you could participate in, whenever you are having an appointment, you can always ask if there are any research trials that you think it would be relevant for you to participate in. So there's a number of different ways of doing it. Hopefully today's presentation has been a great demonstration of why getting involved in research, even if you don't have an active health issue, is really worthwhile to do and can have very strong direct benefits for you. And I hope you'll all consider signing up for us soon as well. Thank you very much.
Thank you, Jonathan. Very informative, most helpful. On to some questions now. I think looking at the questions that are coming through, the majority of them are basically expressing concerns about the fact that it is not usual in the UK for patients to be advised whether they've got dense breast tissue or not. And I believe it was only made law in America at the end of last year. And so with the movement to change this and inform patients what their grade density, their breast tissue is, how can we sort of move this along? I mean, Louise is doing a great job publicizing it, but surely it needs to be done at a national level. What are your views,
So,
Fiona?
yeah, so one of the concerns that the National Breast Screening Programme has is that if they tell people what the breast density is, all they're going to do is cause alarm and they can't offer anything. And so they're worried that they're going to push people into private care where you can access these supplemental imaging tests. And then all it's doing is driving inequity across the health service. So that's one of the main reasons. The other reason they said was that they weren't quite sure the best way of doing that, but I think we've mainly solved that. There's a number of tools available that can give a measure of breast density, and they're relatively similar one with another. There may be slight differences. One concern the screening program raised was that, if you lived in Edinburgh and had your breast density measured by one particular company and moved to Cambridge and we were using a different breast density tool, then you might be given a slightly different result. But that's just, I think we just have to accept that's one of the shortcomings, that there's always a bit of overlap between some of the categories of density. One of the things we would like to see is the screening program adopting these new techniques. But I think, someone mentioned the workforce issues in the chat, and I think it's important that we start with a feasibility study initially and choose people or offer it to people who have dense breast, but who are also at increased risk of developing breast cancer. Somebody in the chat said, oh, with dense breast tissue is higher risk factors having the BRCA gene, the breast cancer gene. And the answer is no, BRCA gene carriers are at much higher risk of developing breast cancer than the population who have dense breast tissue. But one thought is that we identify people who've got dense breast tissue. That's probably about 30% of our screening population, and then ask them to fill in an online questionnaire, as we did in our study. And women are very good at filling in their family history information and what weight they are and some other factors that contribute to risk of developing breast cancer, like sort of drinking alcohol and things. And so from that, you can calculate what the risk might be. And you could then say, okay, you've got dense breast tissue and you've got increased risk from other factors, and then offer additional imaging to those individuals. And so start small and make sure that we can deliver that across the country, in the different screening centres, and then gradually build it up. There's been some cost effectiveness work, and it certainly looks as though both contrast mammography and the fast MRI scans are cost effective in the screening program. But I need the program to kind of acknowledge it.
Yeah,
They're about to publish some work, and so yeah, hopefully, because that's kind of like the first step. They need to be convinced it is cost effective, and then the next step is then making sure that they have the capacity. And I think one way of rolling it out is the looking at an online risk questionnaire. We use the Cambridge one, the CAN risk questionnaire. But in the 10-year plan that was just published, I saw, interestingly, that the government is very keen to increase genomics and look at polygenic risk scores. And that's where you take a little piece. Well, in our study, we started off taking a little smear from inside your cheek. And then we looked, from that, you can take little pieces of genetic information called SNPs, single nucleotide polymorphisms. And from that, you can calculate this polygenic risk score. And if you take the polygenic risk score, the online questionnaire information, and the breast density, you can get down to about 5% of the population who are at genuinely increased risk of developing breast cancer where the mammograms aren't being helpful, and you could start off offering them, something extra which would really help them.
In,
So
in-
That's
Fiona,
a
I'll
very
just
long
jump.
answer. I'm sorry.
I'll jump in quickly and say, as you mentioned, the National Screening Programme is reviewing the current evidence, which is something that I think that was already underway, but has been done additionally as a result of the study that we've just talked about, and I have posted the link on to the statement from the National Screening Committee into the chat. So if anyone wants to go and have a look at it, as Fiona said, they are currently reviewing the evidence, and the expectation is that there'll be some statement from them further over the summer, which we hope will at least say something about telling people about their breast density, and hopefully we'll go further in terms of providing supplemental imaging as well.
Yeah, I think it's important because reading some of the comments and questions in the chats, people who have got breast cancer diagnosed in one breast not being able to get the necessary screening of the second breast, it must be soul destroying for them. So we desperately need to do something. Fiona, in your answer, you mentioned that people being forced into sort of private practices to look at different ways of evaluating things. One of the things that came up in a question that I've been given before tonight was that several online clinics are selling infrared screening tests to diagnose temperature hotspots in breasts. Whereas conventional mammograms can be painful, this is being sold as a pain-free screen. Is it a valid diagnostic tool?
That's a really interesting question, and thermography and or versions of it have been around for, oh gosh, nearly 40 years. And the problem, the real reason that it hasn't taken off as a screening test is that it just doesn't pick up the cancers. It doesn't pick up the small cancers. It's not a very sensitive technique.
Mm-hmm.
So that's always the concern, when I hear of somebody going for thermography and maybe not having a mammogram, it kind of, I just think, oh goodness, what could be being missed here?
Indeed, no, it's frightening. Sorry, I'm just looking to see if there's anything else in the questions that I've
Fiona,
missed.
can I jump in and give you a quick one just around, so how would a woman know if she has dense breasts?
So the only way of finding out is to attend for the screening mammogram. You really need to have a mammogram, and that is one way of finding out whether you've got dense breast tissue. And I can't kind of emphasize enough the importance of attending for mammography, because although it's not great in people with very dense breast tissue, it does pick up cancers, and so it's really important for people to attend and be in the system.
But as far as I can make out, people aren't being told that they've got dense breasts. Is that correct?
That's correct. That's correct.
So even though the people doing the screening are being able to categorize them as A, B, C, or D, the patient themselves are still not being told even when they request it. Is that correct?
That's correct. It's the screening program policy not to record the breast density on the IT system. So we don't record it, and we've been told we should not be telling women what their breast density is. Now, different screening units have different opinions about that, and some do tell women what their breast density is. And if people ask, obviously, when they attend the symptomatic breast clinic, if they come with a lump or a problem with their breast, and they ask us what the breast density is, we always tell them if they ask.
Okay. I think that we've covered all the questions. I can't see anything that we've missed. A lot of people are commenting on the fact that they don't know. A lot of people are saying that they have been told what their density is when they've been in the States, for example, and then so over here the diagnostic procedure being different. But unfortunately, we can't give them an answer, can we, until the system is changed. So on that note,
Can I just say,
yeah.
Keith, that ironically, after all the study, I've just had my annual checkup following the cancer, and I'm now back to mammograms again because the study's finished. So I'm sort of back to square one again. So hence I'm doing all I can to try and get this changed, and help wherever I can.
Exactly. It's as someone is saying here, we're told risks about everything else, and it's their body they want to know. So we've got to do as much as we can to try and bring it to the fore. So thank you for what you're doing.
Thank you.
On that note, I'm afraid that we're running out of time. And so I'm going to have to draw the meeting to a close. But first of all, I want to say a big thank you to everyone involved. Fiona, thank you very much for giving a sort of fascinating insight into the breast cancer detection process and its consequences. I'm sure your research will potentially save an awful lot of lives if and when we can get it adopted. And Louise, thank you particularly, because sharing your personal experience with us, it's interesting to hear the outcome of a scientific study from a perspective of a patient that was involved in it. It's quite unusual to do that. So keep up the good work, keep publishing, keep publicizing your situation so that we can perhaps get somewhere with it.
Thank you.
Jonathan,
there is more in the pipeline, Jonathan, isn't there?
That's great. Well, thank you also to Jonathan for giving us the overview of the research. It's very informative, and I hope that people listening are going to go as you've requested and log on and log in, as it were. So thanks again. Thank you also to Namu and the communication team for arranging this meeting. It was very good. Before you go, could everyone please complete our short survey? The link is going to be in the chat box at the top of your screen. So please log in and do your stuff, as it were. Also, if you'd like to listen to this webinar again, a recording will be posted on the CUH website by the end of next week. So a chance to listen to it all again. So thank you all for attending tonight. Much appreciated. And again, I urge you to become members of the Trust via the CUH website, which I'll repeat is www.cuh.co.uk. And by being a member, you can feed back into the system to help us make change. So on that note, I'd like to say good night, everyone. Thank you very much indeed.
Thank you, Kevin.
Thank you
Thanks,
so
Matt.
much, everyone.
Thank you. Good night.
Thank you.